Thank you, everyone. So I'm Ying Liu. I'm one of the GYN medical oncologists from Memorial Sloan Kettering Cancer Center in New York City. I'm also duly appointed on our clinical genetic service, so I really enjoyed Dr. Paragamian's talk, and I serve as the lead of our inherited GYN cancer program. And I'm really excited today to talk to everyone about the role of PARP inhibitors in GYN cancers. These are my disclosures. So our objectives today are to go over briefly just a quick overview of what are PARP inhibitors, and then we're going to take a deeper dive into the role of PARP inhibitors in ovarian cancer. We're going to talk a lot about upfront therapy, go deeper into some of the studies that were mentioned previously, and then also talk about recurrent disease. And then we're going to talk about, is there potentially a role for these PARP inhibitors in other GYN cancers? I'm going to show you some new data, and then we'll go over some clinical pearls, talk about side effects, how to give these medicines, and then finally we'll end on some future directions. Okay, so I want to show everyone this timeline of PARP inhibitor development just to give you a sense of how long it took to get these drugs into the clinic and to our patients. So the first description of the PARP enzyme occurred in 1963, and it wasn't until 1980 that we discovered the first PARP inhibitor. Fast forward a few years, 1990, 1994, this is when we discovered the BRCA1 and 2 genes. And it wasn't until 2003 that the first patient received a PARP inhibitor, what would go on to be rucaparib. Shortly afterward, we had the back-to-back Nature papers that describe this concept of synthetic lethality and why PARP inhibitors would work in these BRCA1 and 2 deficient tumors. And then finally, 2014, this was the first FDA approval of a PARP inhibitor, olaparib, in ovarian cancer. So over 50 years from discovery to drug development. These are a few of the PARP inhibitors currently in development, and I highlighted the 3 that have approvals in ovarian cancer. So olaparib, niraparib, and rucaparib, and this is what I'm mostly going to focus on today. And we've talked a little bit about the mechanism of PARP inhibitor. There's a few different mechanisms that they may work through. The major one is synthetic lethality. And as we've heard before, in these BRCA1 and 2 deficient cells, which cannot use homologous recombination as a high fidelity way to repair double-stranded breaks in DNA, they're really relying more on these single-stranded DNA pathways, such as base excision, which goes through the enzyme PARP, and the PARP inhibitors block that. And so when you block both these mechanisms of DNA repair, that's that synthetic lethality that everyone talks about, and that leads to genomic instability, leading to cell death. That seems to be the major mechanism of PARP inhibitors, but there are some other mechanisms. One of them is that if you block PARP, if you block this base excision repair, you are shunting DNA repair towards some of these more error-prone DNA repair mechanisms, such as non-homologous end-joining, or NHEJ, and that also creates more genomic instability, leading to cell death. And then finally, there's this concept of PARP trapping, which is when a PARP inhibitor takes the PARP enzyme and they create these DNA complexes at the replication forks. And this, again, creates a lot of genomic instability by not allowing the cells to repair their DNA, leading to cell death. All right, so let's take a deeper dive into ovarian cancer. And the reason that PARP inhibitors work so well in ovarian cancer is that 50% of high-grade serous ovarian cancers, which are the most common type, exhibit this homologous recombination deficiency phenotype, or HRD phenotype. As we've heard before, about 15 to 20% of females with ovarian cancer have germline mutations, mostly BRCA1 and 2, but some moderate penetrance genes as well that help to contribute to this. But there's still, a good portion that have this HRD phenotype from a somatic event. So how do we treat ovarian cancer, and where do PARP inhibitors fit in? So in patients with newly diagnosed ovarian cancer, the treatment is still surgery and platinum-based chemotherapy. This can happen in 2 ways. You could have a neoadjuvant approach, which we term a sandwich approach, where you have chemotherapy, surgery, and then more chemotherapy. Or you could have primary debulking, where you go to surgery first and then chemotherapy afterwards. The goal is to achieve remission for our patients, and unfortunately we know that recurrence rates are high. 80% or more of our patients will recur. So there's a lot of interest in what we can do in this space to keep our patients in remission for longer and treat them when they recur. So this is where PARP inhibitors really have a role. So let's talk first about first-line maintenance. We've heard about these studies, but I wanted to take a deeper dive. This is SOLO-1. It's a phase 3 trial of maintenance olaparib for patients with newly diagnosed advanced ovarian cancer and a BRCA mutation. So these are all patients with stage 3 or 4 newly diagnosed ovarian cancer who had a response to their upfront platinum-based therapy, who all have known germline BRCA1 or 2 mutations. They were then randomized to olaparib versus placebo for 2 years and looking at outcomes of PFS and OS. These results were presented initially at ESMO in 2018 and led to the FDA approval later that year. And this was the New England Journal of Medicine paper summarizing the results. And our main results were that after a median follow-up of 41 months, there was a 70% lower risk of disease progression or death with olaparib compared to placebo. What this means is that at 3 years, the PFS was 60% for the olaparib group compared to 26% for the placebo group. And you can see the clear separation in these curves there. The common side effects that we saw in these studies were anemia and nausea, and I'll go into more detail. And one of the feared side effects of PARP inhibitors, the AML, MDS that you can subsequently see, only occurred in 1% of the olaparib group and 0% of the placebo group. At ESMO in 2020, they updated these PFS results with a 5-year follow-up, and again, we're seeing similar results. These curves are still separating. And just a couple of weeks ago at ESMO, we saw the 7-year overall survival results. And again, maintenance olaparib provided a clinically meaningful OS benefit. Put it a different way, after 7 years, 67% of patients were alive on the olaparib arm compared to 46% on the placebo arm. And keep in mind, almost half of the patients on the placebo arm ended up getting subsequent PARP inhibitor. A similar study, the PALA-1 study, this time maintenance olaparib but with bevacizumab, which is an anti-VEGF antibody, again in patients with newly diagnosed advanced ovarian cancer who had responded to their initial platinum-based chemotherapy. Again, randomized to olaparib versus placebo for 2 years, but this time with bevacizumab, and very similar outcomes, PFS, OS, quality of life, secondary endpoints. So, the overall PFS results for this study were positive, but what I wanted to show everyone was the planned subgroup analysis looking at HRD status. And you can see that they subsetted these patients into 3 groups. So we have the HRD positive group that included the tumor BRCA1 and 2 patients, the HRD positive group excluding tumor BRCA1 and 2, and then the HRD negative group. And you can see that the PFS benefit here is really only in the HRD positive group, and that you don't see a statistically significant difference in that HRD negative group. And just a couple of weeks ago at ESMO, they presented the updated OS data after 5 years. And again, you see a similar trend. So significantly improved OS, overall survival, in the BRCA group. Not statistically significant in the HRD positive group, excluding the BRCA patients, but still, the curves do separate there. And then you can see the HRD negative group, again, really no difference here. The third study, this is the PRIMA trial, this time niraparib therapy in patients with newly diagnosed advanced ovarian cancer. So this is a little bit different in that these patients were a little bit higher risk. They, again, received upfront platinum-based therapy, had to have a response, and were randomized to niraparib versus placebo, this time for 3 years. There were some planned adjustments of the dosing for body weight and platelets, and then also the outcomes of PFS OS with some subgroup analyses as planned. So again, this was a positive study overall, but I want to show you guys the results by the different biomarker subgroups. And here again, you see that the greatest survival benefit is in that HRD positive group. Here you see a good benefit in both the HRD positives with the BRCA mutated tumors and HRD positive with the BRCA wild type. Here, instead of calling this HRD, we're calling it HR proficient, but it's essentially the same thing. And although you see a statistically significant improvement in PFS, the degree of separation of the curves, the benefit is smaller in this population. So this is a summary of the current FDA approvals for frontline maintenance in ovarian cancer in those patients with germline or somatic BRCA1 or 2 mutations, which by definition means HRD phenotype. Olaparib alone is approved as maintenance in the frontline setting. For those that are HRD positive, olaparib plus bevacizumab is approved. For all patients, niraparib is approved as well as bevacizumab. And the HRD test that was used as a companion diagnostic in these studies was the Myriad MyChoice CDX test. Just of note, rucaparib is not currently approved in the frontline setting, but there is an FDA application that is being considered based on their positive study. And then volaparib, although we do have Velia, which it's currently not FDA approved in any setting clinically. So let's move on to the recurrence setting. I show this figure just to show you guys the different approvals and the timelines of the 3 different PARP inhibitors in ovarian cancer in the recurrence setting. But I put together this table just to try to simplify things for everyone because there's been a lot of change in the last couple months and even couple of weeks and even on Friday for this indication. So as of today, there are no FDA indications for PARP inhibitors as treatment in ovarian cancer. And this was due to some data showing potential overall survival detriment in patients treated with PARP inhibitor compared to standard of care chemotherapy. So actually the drug companies removed these indications. There are still approvals for all 3 of these drugs as maintenance therapy in the platinum-sensitive recurrence setting after response to the most recent platinum-based regimen. And if anyone is interested, ASCO just came out with a very nice summary just on Friday, which I didn't have time to include, that goes over all the data and these recommendations as well, but a lot of change in this space. The one study I do want to mention from the recurrent setting is the SOLO2 study. This is very similar to SOLO1. Again, patients with germline or somatic BRCA1 or 2 mutations, this time in the recurrent setting, platinum sensitive after 2 or more previous lines of platinum-based therapy with response to the most recent regimen, randomized this time to olaparib versus placebo until progression because we didn't know if this drug was going to have benefit with the primary and secondary endpoints that you see on the screen. And I want to just point out the final OS data from this study showed an unprecedented greater than 1 year benefit in overall survival in these patients. Which was really a first of its kind in ovarian cancer. But one of the things I want to make sure we all understand is that when looking at the adverse events, we see very high rates of MDS AML. We see 8% in the olaparib group versus 4% in placebo, which probably recognizes the effect of multiple rounds of platinum-based therapy. And this is a big factor for overall survival, a secondary hematological malignancy here. And then finally, I wanted to just show you guys the data from the phase 2 LIGHT study. This is a study of olaparib treatment in the platinum-sensitive setting in various biomarker subgroups, more to just kind of drive home the potential differences we see in responses based on these biomarker subgroups. So this was a study of olaparib treatment in women with recurrent platinum-sensitive ovarian cancer in 4 cohorts. We have a germline BRCA1 and 2 cohort, a somatic BRCA1 and 2 cohort, an HRD positive BRCA wild type cohort, and an HRD negative cohort. And this is a figure here showing the response rates. And while you can see responses in all 4 groups, the biggest responses are really in the BRCA1 and 2. Both germline and somatic are pretty similar. And then next in the HRD positive, and then finally in the HRD negative group. So then how should one approach the use of PARP inhibitors in ovarian cancer? It's a question of balance. We really should look at BRCA status and HRD status. Subgroup analyses seem to show the benefit is greatest in the BRCA1 and 2 and HRD positive groups. We should think about line of therapy. Maybe we should use these more in the upfront setting where, there may be a chance to potentially cure these patients and maybe where the risks of side effects in MDS-AML may be lower. We should really look at bone marrow function because of the risk of MDS-AML, and we do think this becomes worse with more and more lines of therapy. And then finally, we need to consider toxicity. What are patients experiencing? What is their quality of life on these medicines? This is very important. And speaking of toxicity, I wanted to go over some of our clinical pearls from our experiences giving these medicines. Some things to think about. These are reasonably tolerated medicines, but there are common side effects that it's important to review with your patients. There's fatigue. It can be significant. There is GI toxicity that can come in different forms. Some patients have nausea. Some have more diarrhea. Some have this dysgeusia. They just say things don't taste right. They just don't have an appetite, and that can significantly affect quality of life. And then there's the myelosuppression that you have to monitor, and then the risk of the MDS-AML, which you have to carefully counsel on. And because of these side effects, the discontinuation rates are high as 21% in some of the studies. Some relative contraindications: if a patient has significant myelosuppression, this may not be the best option for them. It may be hard to tolerate full doses. If there's a lot of baseline concern for MDS-AML, this may also not be the best option. If patients have significant nausea, if they struggle with small bowel obstructions, it may be hard to take these pills and to absorb the medicines. And then some special considerations, the unique side effect of MDS-AML really does need to be carefully counseled on, and we do need more long-term data to really quantify the rates of this. Cost is a big issue. Even if these medicines are covered by insurance, sometimes my patients have very high copays that make this quite a burden for them. And then finally, you have to consider the drug interactions here because there can be some significant ones. I wanted to show this table just to give you guys a sense of the specific toxicities and some of the differences between the three PARP inhibitors. For the most part, you see the fatigue and the GI symptoms, the nausea with all of them. You do see a degree of myelosuppression with all of them, but this seems to be greatest in niraparib, particularly that thrombocytopenia. A third of patients can have grade 3 or 4 thrombocytopenia here, so this is something you have to watch out for. And then the hepatotoxicity is something that's very specific to the rucaparib. All right, is there a rationale for use of these PARP inhibitors in other GYN cancers? So we're starting to see more and more data showing an association between germline BRCA1 and 2 mutations and a risk of uterine cancer, specifically the most aggressive type, the serous types of uterine cancers. And although there's lots of epidemiological data, I wanted to show you guys this more translational study from our group that actually looked inside the tumors of women with germline BRCA1 and 2 mutations to see if these germline mutations were really influencing tumor development. And we do that by looking at something called loss of heterozygosity or biallelic inactivation within the tumors. And if we see that, we infer that this germline variant, this germline mutation, is really contributing to why these patients got this cancer. And we saw that in 100% of these BRCA1 patients and many of the BRCA2 patients. And we see that these tumors have an HRD phenotype. And so that's some of the rationale for why PARP inhibitors may have utility in endometrial cancer. And this is just a selection of various ongoing studies looking at both monotherapy and combination therapy in endometrial cancer. So finally, what about PARP inhibitor resistance? Because this is definitely something we're seeing in the clinic now that more patients are getting these drugs. And so there's a couple different proposed mechanisms for this. The major one seems to be restoration of homologous recombination through direct reversion mutations that restore this function in cells. But some other mechanisms are just protecting that replication fork, preventing that PARP trapping, that complex. There are pumps that are upregulated that seem to lead to more drug efflux out of the system, out of the cell. And then there's other signaling pathways that seem to get activated to overcome the PARP's ability to work. So there's a lot of ongoing studies. I just leave this very complicated figure just to show you guys the different targets that people are exploring, the different combinations that are ongoing to try to overcome resistance. So in summary, we talked about PARP inhibitors and how they target cells with deficient homologous recombination through synthetic lethality. We talked about how PARP inhibitors are approved in multiple settings in ovarian cancer and are improving outcomes and survival. We saw that the effect is likely greater in patients and tumors with BRCA1 and 2 mutations and an HRD positive phenotype. And we talked about the careful monitoring and the balance of the side effects, especially the risk of MDS-AML. And then finally, we talked about some of the novel clinical trials investigating PARP inhibitors in other GYN cancers and in combination with other targeted agents to overcome resistance. Thanks everyone for your time. I don't know if we have time for questions.
Are there any questions in this room? I do have a few from the virtual audience. Sure. Would the MDS potential reverse itself with discontinuation of PARP inhibitor?
That's a good question, and I don't know if anyone knows. You know, if once you've developed MDS, you know, it's almost like the damage might already be done, or that process may already be initiated. And you know, there's different types of MDS-AML. That's a spectrum in and of itself, so it potentially could affect the trajectory. I will say we are in practice considering shorter and shorter durations of PARP inhibitor therapy. You know, in our frontline trials, there are standard lengths, 2 to 3 years, but in the recurrence setting, it was until progression. And so some of those patients on for example, the SOLO2 study were on PARP inhibitors, 20% were on them for longer than 5 years. And so we do think that the risk of MDS-AML is time dependent.
And the other question is, what combination strategies with PARP inhibitors seem promising? Anything going on with IO?
With IO, yeah, these are very good questions. So there's some promising data looking at combining PARP inhibitors with ATR inhibitors. There's a few trials there, and there's some very promising translational data. With IO, you know, IO has been tough in the ovarian cancer space. There's definitely been a number of studies looking at PARP inhibitor with checkpoint to see if that could increase response rates, selecting with different biomarkers. So far, these are all still very preliminary, but they are studies we're all very excited about.
Any other questions in the room? Wonderful. Thank you so much.
Everyone.